So certainly what I've heard is a lot of contextual ideas for the roundtable to consider as we focus the position paper to incorporate additional perspectives. I think that's going to be an important focus for us to consider as we go through the rest of the day. But for the next 20, 25 minutes, let's have some questions from the roundtable and indeed from the audience to see whether or not there are some other issues you would like to address or to address some of the comments that the panelists have already made. Lindsay?
Okay. Yes, that was a fantastic panel. I appreciate all the comments. I have a question for Dr. Washington. You made a really powerful statement that conjured up this incredible image in my mind about the need for having soldiers in the field to push equity. Can you tease that out a little bit more, and what, in your perspective, what kind of workforce, what kind of background do they need? What kind of skill set do they need? How are you going to recruit and how are you going to train these soldiers in the field?
Yeah, so, and thank you for the question. I'll go back to a statement that, that George actually made. The frameworks are conceptual. They're broad in context, and we kind of draw, here's the pathway to success. But the real application of that happens locally. It happens on a community level. And what that looks like, so ultimately what that framework transfers into, could be something very different in Chicago than what it is in New York, in both urban areas, than what it is in an urban part of, I don't know, California. And so it is so important, and now I'm going to use Alicia for a second, it is so critically important to make certain that, and the paper addresses this, so we should definitely broaden it, is the workforce diversity piece. I don't think that we have taken this patient-provider concordance piece really to the extent that we should. And what I mean by that is that really analyzing our clinical teams, who we have on our clinical teams, and not only just cultural competence, but how are we hiring from the community? How are we recruiting from the community, folks that look like me, folks that have similar backgrounds to me? Because what we have found in research shows that concordance actually produces better outcomes. So even where cultural competency is strong, when there's that concordance in place, the outcomes are even better. And so we need to make certain that we're fostering systems that do just that. And it's not an easy task. It's not an easy task. One of my personal commitments to my own work is that as I began to work nationally, that I would always stay on the ground. Can I tell you how difficult that is? It was the most challenging thing that I've ever put on my plate, because if you're up here, then you're up here. If you're down here, then you're down here. But in order to be up here, you got to know what's going on down here. And that's my personal commitment. And so, we really do need to make certain that we are, and Berwick even mentioned some of this in his last commentary during Quality Conference, as hospital administrators, we need to be figuring out how we're going to recruit, ex-felons. How are we going to change our system so that we're now promoting the type of change in the community that we're really talking about? And so, it's going to require us to really take a critical analysis of who we have, on our teams in terms of the soldiers, where our gaps are, and it's not just filling with cultural competency. It's actually creating systems that are recruiting from the community, making partners in the community, and driving, that whole thing 360. So I hope that answers your question, but it's really about workforce diversity, it's about community partnerships, and it's about ensuring that we have an understanding that these frameworks are going to look very different, in an applied sense in every segment of the country. And we need to respect that. We need to own that, right? And then we need to create systems that help to support that.
Thank you. Cindy?
Also a question for Dr. Washington. You talked about the patient and family role in measurement development, and I think that's incredibly important. And I was wondering whether you could kind of walk through for us your vision of how that engagement happens, at what points in the process of trying to develop, roll out, et cetera, integrated measures. Can you help us think that through?
Question.
I know, I'm
Yeah.
famous for that.
So first, I think it does really begin in theory with challenging a lot of what's already out there. It's widely accepted, and folks are moving forward with it like the Bible, and it's wrong. And wrong in the sense that it does not consider the equity piece, you know, with liberty and justice for all, period, the end. And if we're going to get there, see, person implies that we're looking at individuality of every person in this room. But how do you do that when your system only looks at the aggregate? Makes no sense. So what we have to do is really begin to challenge the frameworks that are out there around person and family engagement, insist upon the inclusion of equity as a foundational component of that work. And it's because, you know, this thing, that train is left, it's moving, and it's going really, really, really fast. And it's producing results. Don't get me wrong. I mean, you know, from a quality improvement standpoint, we are doing the right thing in terms of adding patients. But I can tell you, as I tour and partner with and go to organizations across the country, that diversity and inclusion does not exist. So it's one of the first areas, you know, that I began to challenge is so every, I believe it's New Hampshire has a mandate that you have a patient on a board. Other areas are beginning to move in that fashion. There's a strong movement across the country to do person-family advisory councils with hospital organizations.
I'm going to just try and jump in here because I think I was very unclear. I misled you by using the term patient and family engagement, which led you into talking about that very important topic. But I'm talking about it specifically with respect to the charge for today's workshop, which is around integrated measures. So I thought I heard, and maybe I misheard you say that you thought you had in the past developed measures.
We have,
and
it's in
Okay,
and that equity, those equity metrics were actually embedded in the person-family engagement metrics. So if you understand the measurement system, because the PFE stuff is widely accepted, and everybody says we got to do that in order to improve quality. We got to have patients at the table. So nationally, what we did was through the National Partnership for Patients was we developed 5 metrics to be included in the overall evaluations of those 3,900 hospitals that were participating. In that work, that's where the equity piece was birthed. That's where we said, okay, we can't just do this and have these 5 metrics in the aggregate. We now have to really begin to parse this out so that equity becomes a part of the agenda. So this next cycle, what we've done through Transforming Clinical Practice Initiative, which is also another innovations network, within that PFE framework, we have our equity metric embedded in there, and that's where the health literacy piece is embedded in there. So what we've done is we've essentially taken the framework of PFE and insisted that equity be a part of it and included the measures there because, again, that piece has been widely accepted.
So, Ernestine?
Yes, you may not see me for the light. I appreciated all of it was refreshing to hear some of your perspective and say the challenges that we will face as we try to deal with integration. And I'm not so sold that integration is always the panacea for solution, and I just sit here and I was thinking about, we've talked about education integration since the 50s, mid-50s, and we still don't have equity when it comes to education, so we need to be mindful of that and what has happened in urban and rural communities. But I'm going to go a little bit further off of your own area and try to get some of the concepts that you're talking about. How do you include the voice of the constituent in the mental health? I understand oral health, I work in that area also, and I understand in the primary care setting, but how do you work this through in some of your experience for the clients who are coming in from the mental health lens?
May I start? Yeah. I have a couple different answers for you, how it works at La Clínica del Pueblo. One is that as a federally qualified health center, a majority of our board members are patients of our services. And to be a patient, you have to have an you have to have a record in our electronic medical record. It does not have to be as a primary care patient. So we absolutely have patients on our board who are users and consumers of our behavioral health services. Hiring from the community that we serve, we have extensive substance abuse outpatient services as well as mental health sort of spectrum services. We're able to incorporate patients into our staff or as promotores as well. That's sort of our pipeline is patient to volunteer and promotora to staff, and many of those folks have been consumers of our services, as well as hiring the licensed staff who also come from the community we serve. So our mental health clinicians are all first-generation Latina immigrants, and they bring a lot of that perspective into their care. That being said, it's really a challenge. We have a lot more vocal patients who are primary care patients, and the stigma and shame that comes around the area of behavioral health prevents a lot of people from self-identifying and standing up. Clinic has been open for 34 years now, and we've been providing behavioral health services for 33 of them, and it has been a 33-year project to destigmatize behavioral health care within the community, and really bring folks out of the shadows. It's an ongoing challenge. I guess the other thing that I would say is the behavioral health integration work that we've been doing, bringing behavioral health care into the primary care area has both a destigmatizing effect, but also channels patient engagement and involvement through some of the non-behavioral health pathways that are maybe safer, and allows behavioral health patients to talk with their primary care doctor about whether the behavioral health care they're getting is meeting their needs or beyond.
And I would just add, in addition to Alicia's points, caregivers. Someone made the comment about caregivers. They are so critically important to this. And so when we talk about patient advocacy, we have to absolutely include caregivers into that. And to the other point that I believe she was making was, patients are along the continuum. So if you caught me in 2009, right post my dad's death, I wasn't ready to talk about it. You talked to me in 2010, 2012, I'm a different person and I have a different way to shape the story. And so I think that, really there's work involved in building that level of capacity. But albeit in a person's initial inability to be a part of it, caregivers are the first place to go for inclusion.
So I'll answer the question too. I think from the standpoint of mental health, serious problem that is a lot of lack of resources in our community, and socially we've not stepped to the plate and provided the resources that particularly that group, the severely and persistently mentally ill, need in our community. So our board is we're the largest collaborative in the country as far as size of organization. We elect our board from the people we serve, and so we have people on our board who are very much concerned about this issue, and that's been a priority of ours. We've used some of our assets to build inpatient facilities for the acute, persistently mentally ill, which has no profit kind of flow in contemporary healthcare, but have done that. We've redesigned the flow in emergency departments so that the emergency departments aren't continuously diverted by the congestion in the emergency room, and worked with the county and other systems to streamline the processes around the severely and mentally ill. We have a major initiative with respect to perception of mental illness in the community with the National Association of Mental Health. I forget the exact name of that, but in our community. And so we work on that issue. In primary care, we've integrated the care of people with depression, now moving to more common mental illness in terms of primary care, and provided resources to look at that in terms of coaching, both psychiatric as well as counseling resources and follow-up resources, as well as data tracking in terms of that. And I would remind this group that our objective is to improve the health of the people we serve, and the definition of that includes not only the length of life, but the distribution of that benefit within the population, which covers the equity sort of frame. And so that drove our measuring of these performance in mental health and behavioral health by all of the characteristics that could be cross-cut by race, ethnicity, language preference, and then setting objectives to move that out. So that's how I would answer that question.
May I just add on one other thing? In the sense of cultural competency, linguistic access, and health literacy, I think health literacy around behavioral health is abysmal. And one of the things that we do in one of our signature programs is what we call a psychoeducational approach, which is really teaching the language of mental health. It's sort of a cross between a support group and a class. And it has led to significant self-referrals for mental health, way beyond what we could have imagined, because we're teaching what is depression, what is anxiety, what is PTSD, and in a safe setting. Being able to measure the impact of that would be thrilling. and thinking about health literacy in a behavioral health context isn't something that we normally talk about. We talk about, can you read your pill, your pill bottle, and understanding concepts around behavioral health would, I think, yield enormous, enormous benefits.
Ignatius, you want to make the last comment?
So I actually wanted to say in California, there's been this work supported by the California Department of Public Health called the California Reducing Disparities Project. And it's looked at mental health and behavioral health in the racial ethnic populations, but also in the lesbian, gay, bisexual, and transgender populations, and really developed this notion of a rich body of what they're calling community-based evidence as opposed to evidence-based practices. So things that haven't been done by researchers in the usual model, but that the community knows is effective and works. And a lot of it is peer models. A lot of it is using mental health peer workers. And then the great thing is now California is putting money into some of those models to actually document through the usual research methods their effectiveness.
Well, once again, thank you very, very much. Not only this panel, but